HerniaTalk Live. Welcome to HerniaTalk Tuesdays. As you know, my name is Dr. Shirin Towfigh. I do this for you all every Tuesday night. The purpose of this is to answer any of your questions related to hernias. And every week we have a special guest. Tonight I'm your guest because I know that you have a lot of lingering questions that sometimes can't be answered by our specialists. I hope you find this very entertaining and educational. You can follow me on my different social media platforms on Twitter and Instagram at HerniaDoc. Many of you are currently on Facebook Live at Dr. Towfigh. And this video will actually be rebroadcast on YouTube. So as you know, I am a laparoscopic and hernia surgery specialist. All I do is hernias. Everything I do is hernias. And we do a pretty good job, I think, with really amazing guests. We've had some really cool specialists from urologists and anesthesiologists. We have pain management doctors coming up, physical therapists, rehab doctors, gynecologists we've had, in addition to colleagues of mine that do operations for hernias. We've had plastic surgeons, people who deal with chronic pain. The Shoulder Clinic was here. So a lot of great specialists and colleagues of mine that I know and trust are on HerniaTalk Live with me. I invite them personally. I have worked with them, I know them, and so they kind of have my stamp of approval. And we have really amazing surgeons coming up as well. But today I thought I would join you myself. We've been so focused on our US elections, and I think now is a good time to just kind of decompress and discuss any of the lingering questions you have. Many of the questions you've had today have been focused on whatever the topic of the week was, whether it was urology or sexual dysfunction or anesthesia issues. And so some of you had questions that maybe I would have been better fit to answer, but we couldn't pick them out at the time of the original HerniaTalk live session because we were kind of really focusing on the specialist that I had as our guest. So I decided today's hour will be focused on all your questions. Ask me anything you want. If I can answer it, I'm happy to answer it. Many of you have submitted questions through Instagram, some through herniatalk.com, which is the original impetus for this live session. And if any of you have not already become members of herniatalk.com, I highly recommend it. It's free. It's a discussion forum. Many surgeons are on it, including myself. I started back in 2013. We have thousands and thousands of members and just a huge archive of questions that you can browse through and search through to help get some of your questions answered. And if you can't find them, then you can submit the questions yourself, and your peers, as well as some different surgeon specialists will be answering them for you. So let's get on with it. Many of you are already on here as a Facebook Live, and so welcome to you all. I will start sharing my screen here because we have tons of questions that have been submitted. I don't think we can get through all of them, but if we can, I will have done a great feat. Okay, so let's start. Many questions were about pregnancy. This one was from a female. Any advice for women who have an inguinal hernia and plan to get pregnant within 5 years? We discussed this earlier. I think it was the session with Dr. Shirin Towfigh. She's a specialist over in Virginia, in the Fairfax region. So Dr. Bachman is really smart, and she's done a lot of research on hernias and women. Also, Dr. Gina Adrales, another female hernia surgeon with interest in women's hernias. Obviously, I have a huge interest in it. So pregnancy is unique in that your abdominal wall changes during the 9 months. And so any operation on the abdominal wall should be done judiciously. The belly button and the upper and mid abdominal wall in particular change a lot, whereas the groin area doesn't really change much. So in general, as a rule, we feel that any hernias of the abdominal wall, so umbilical hernias, ventral hernias, diastasis repairs, should not be done during your fertile years and should be delayed until you're done with all pregnancies. Whereas groin hernias, it doesn't matter as much, and women get their inguinal hernias repaired before having pregnancies and have no issues during their pregnancy. There's no higher risk of hernia recurrence, no chronic pain issue. That's due to the pregnancy, and so we do recommend that if you have an inguinal hernia and it's symptomatic, that means you have symptoms from it, that you can consider repair at any time. You do not have to wait until you're done with all your pregnancies. So that's what we think is true for pregnancy. That said, if you look at the data, there's not a lot of good data, but the data that we do have, if you have patients that, they looked at patients that had inguinal hernias and did not undergo repair and saw what happened during their pregnancy. Basically nothing happened. So the risk of you having an emergency problem or some inguinal hernia, groin hernia problem during pregnancy, if you don't repair before pregnancy, is considered to be close to zero. Doesn't mean it can't happen, but it's considered close to zero. It's not a reason to repair your hernia. However, for belly button hernias, I think we had a belly button hernia question here. Here it is. Should women with epigastric hernia wait until done having kids before repair? That is true. So the abdominal wall, belly button, epigastric, diastasis, all of those hernias should be delayed in their repair until you're done with pregnancy, because the most amount of stress is actually against that abdominal wall. And so the thought is, if you repair a hernia before pregnancy, then you get pregnant, the chance of that hernia falling apart, I think, has been quoted about 1/3. That's a large number. Also, there's a risk that you'll have pain in the area from sutures pulling, or if you have mesh, the mesh will not stretch, and you can get chronic pain in the area where you're not stretching, or where you have stitches that are going to be pulled through as your belly expands. Whereas if you have a hernia that doesn't really bother you that much, or bothers you a little bit, then you shouldn't have any problems with it during pregnancy either. So Tracy Scher is on. She'll be a future guest of ours. Great, very talented pelvic rehab physical therapist. So thanks for delineation of the abdominal versus inguinal. Yeah, they're very different. And for pregnant women, they do act differently. The next question has to do with imaging. As many of you know, I should have been a radiologist. If the surgery thing doesn't work out for me, I would be a radiologist. I love the arts, and I'm like an artist. I paint and draw, and that's kind of why I like surgery, because anatomy is very much like a three-dimensional sculpture, and you have to really know it and know how to navigate around it to be a good surgeon. Radiologists are also really good anatomists, and they need to understand the three-dimensional body, and then they need to understand the three-dimensional body and then be able to interpret it through a two-dimensional image like a CT scan or MRI. And I really like that. So I think that's really cool. So I actually published 2 papers on imaging and whether the type of imaging you do changes your diagnosis, so ultrasound, CT, or MRI for groin hernias. And we found that ultrasound is pretty good. It's about 50-50 sometimes, which are not good odds, but it's better than a CT scan. For small groin hernias, CT scan's horrible. Something like, forget our data, I think something like 20% or something or less were correctly identified. And the MRI was the best, or about over 90% of the patients that got MRI got the correct diagnosis from imaging. And what we also learned is that the radiologists in general do not look at hernias as kind of high ranking in their list of things to look at. So look at cancers and look at like tumors and the vessels, but they don't look at the abdominal wall. So you can have a hernia anywhere, and it can show on the imaging, but not dictated in the report by the radiologist. So anyone who's seen me as a specialty consultation knows I read my own imaging. I demand that your ultrasound, CT, or MRI CD is actually given to me so that I can download the images. I don't trust the report itself because for hernias, I think I do a better job. It took me years to learn it, but it's something that I enjoy. And I've had a lot of patients. This question is very, very apt, which is how many times does it take to before an imaging is finally diagnoses it? And it can be once or it can be 10 times. I've had people that have had years or decades of pain undiagnosed. And if you went to their very first image, it was there. It just was undiagnosed. And they went from doctor to doctor to doctor. And each doctor read the radiology report, and the radiology report said nothing, didn't mention hernias, or specifically said no hernia. Usually they just don't say anything because they don't even look for it. And because of that one radiology report, that patient got misdiagnosed into other things. They got endoscopies, colonoscopies, maybe it's endometriosis. Should we block this and cut that? And if they looked at the first image, they would have done better. So that is super important to know. It's not that repeating the imaging necessarily gives you the higher chance of it getting caught. It's that you just need the right person to actually look at the images or re-look at images. And so I do offer that. Many of you have actually asked me to do a consultation just to read your images. I don't like to do that. I like to know the whole story, but it is something that I offer as an online consultation. Okay, another live question. Hello, I recently had open mesh surgery on inguinal hernia on the right side, 11 days post-operatively. Okay, this patient is currently 11 days post-operative after an inguinal hernia repair on the right side. The bulge at this point is bigger than it ever was pre-op. I understand that this may have to do with swelling. My concern is that there's a very tight ligament or tendon from the hernia area to the base of my penis, very painful to walk. Is this common? Okay, so open mesh hernia repair, depending on the size of your hernia and how much kind of tissue injury there was at the time of surgery, may cause fluid or blood to accumulate, and you can get really swollen. And so hematoma is when you get blood there. Seroma is when you get fluid there. If you're on a blood thinner or take aspirin, the chance of blood is a little bit higher. So basically, it's most likely that the swelling in the area is not from the hernia coming back. It's mostly directly a result of swelling and or blood forming in the tissues. Now that usually goes away. And so your surgeon should be notified about it to figure out if there's anything that needs to be done. But usually there's nothing to be done. Ice packs work really well. Massaging the area works really well. And with time, all of that should subside. Now for open surgery in the groin, there's also a phenomenon called a healing ridge. Healing ridge is basically a finger. It's about the size of my finger, the width of it, and it's a swelling that you feel along your incision. That takes up to 3 months to go away and become flat. That is just a consequence of cutting multiple layers and then sewing multiple layers back together again. So don't get too worried. Almost everyone gets a healing ridge. So I hope that helps answer your question. All right, keep these questions coming. I'm happy to answer all of them for you. This is a question. What if my hernia never went away after the surgery? Well, depends on what you mean by never went away. If your bulging never went away, then either you have a fluid collection in the area, which is mimicking your hernia, or you have like a weakness in the area. So the hernia itself is fine, but the muscles are weak, or the mesh is bulging for whatever reason. Sometimes some people get like a bridge repair. Imaging helps identify a lot of that. So if you do have bulging in the area where your hernia was repaired, you need to be evaluated for a fluid collection, a muscle weakness in the area, or a bulging of the mesh in the area, which sometimes replicates your symptoms. Okay, this is a question about hydrocele. For those of you that don't know what a hydrocele is, it's a sac of fluid. Hydro means water. Cele means like a sac or like a spherical accumulation. Hydrocele is a sac of fluid, usually in the scrotum in men. It's less commonly in women, although it can occur. In women, we don't call them hydroceles, we call them cysts or a canal of Nuck cyst. So the question is, do surgeons that fix hernias typically treat hydrocele as well? Possibly. So because hydroceles occur a lot in children, either pediatric surgeons or pediatric urologists would deal with addressing a hydrocele, again, usually in males. And those same surgeons know how to fix hernias. In adults, if you have a hydrocele, we have to figure out why. Is the fluid in there because you have an isolated hydrocele? Or is the fluid there because you have a hernia upstream from the fluid sac? So there's your scrotum has the fluid, and then the fluid leaked from the fluid around your intestines. Everyone has fluid around their intestines. It's about a teaspoonful or tablespoonful. It's just enough to moisturize the intestines and allow them to remain moist and kind of move against each other. It's like your body's oil. That fluid may leak into a hernia and cause bulging in the scrotum called a hydrocele. So if it does, and those two fluids communicate, we call those a communicating hydrocele. If it's not the situation and you just have a fluid communication, that's just called a non-communicating hydrocele. So in adults, if you have a hydrocele, you're usually sent to a urologist, like how we've had 2 urologists on HerniaTalk so far. And the urologist will usually treat the hydrocele, and it's like a surgical procedure. What sometimes they miss is the fact that there's a hernia upstream, so they'll fix the hydrocele, and either the hydrocele comes back because a hernia which communicates didn't get fixed, or now they have a hernia and they need a second operation. So do surgeons that fix hernias typically treat hydrocele? So I do. I treat hernias, and if there's a hydrocele associated with the hernia, I would fix it at the same time. If it's a large hydrocele, usually urologists address those because it's further down in the scrotum and the testicle and so on is nearby. So usually the urologists address that. There are urologists that do hernia repairs. We often don't overlap as much as we should. And so if you have a hernia repair that involves a hydrocele, often we deal with it at the same time as a general surgeon. If you have a hydrocele that has a hernia associated with it, the urologist can also address it, but not all general surgeons and not all urologists can do both. I hope that's helpful to your question. Okay, along the same line, this was from the same patient who submitted their question. What does reinforcing the abdominal wall involve surgically if there's no obvious hernia? So this patient has a hydrocele. They went to their surgeon, and their surgeon says, okay, we'll deal with the hydrocele, and then we'll reinforce the abdominal wall if there's no obvious hernia. So if there's no obvious hernia, there's no need to do anything. But there may be a small pinpoint hole. So think of this, because water can go through a crack, everyone's probably dealt with a roof leak. Sometimes there's a pinpoint hole or some crack in the roof, and eventually leaks inside through your ceiling. To try and figure out that process is really hard, but water does creep through those really small areas. So same occurs with hydroceles. You could have a pinpoint hole communicating from the area around your intestines, and that fluid can leak into to make a hydrocele. So some people put like a stitch or two called a Marcy repair to close that hole. That is probably what they're talking about. You definitely should not get a full tissue repair or a full mesh repair of your groin hernia if there's no obvious hernia. Probably what they're saying is that if there's a suggestion that the hydrocele is communicating, then a couple stitches in the area may need to be done, and that's separate from the hydrocele procedure. I hope that's helpful. All right, let's answer some more live questions. This is on our Zoom-based attendee. So is it possible to get a diastasis recti after laparoscopic angular hernia surgery? My doctor noticed a diastasis recti. I'm a male in good shape, and it makes no sense to me. All I can attribute to is the surgery. Anything to worry about? Thanks for all you do. Thank you. Okay, so the answer is no. Laparoscopy does not of any sort, does not induce or cause or promote a diastasis recti. Diastasis recti is a usually genetic problem. So it can happen in women or in men. Women, it's often associated with pregnancy, but doesn't have to be. Men is definitely very genetic. It can be associated with obesity, but doesn't have to be. There are plenty of thin patients with diastasis recti. If you see men, some men as they age, they keep their flat belly. Other men as they age, they have a rounder belly, regardless of their weight. And that's a very genetic kind of situation. So if you got a diastasis recti and you happen to have had a laparoscopic surgery of any kind, including an inguinal hernia, the two are not related. So I hope that, I've heard that question before a couple of times, and we do so much laparoscopy. We don't have people running around with all these diastasis recti. So no, it's not related, but it may have been a coincidence that you had the two. Another live question. Yeah, Jennifer Walsh, shoot any questions today. Well, it has to be hernia related, but anything that I can answer that's hernia related, I'm happy to do so to my top fans. Okay, another live question. I had an umbilical hernia repaired 11 years ago. I got mesh in my belly, wow, 4 to 5 times. Last year, I underwent surgery to remove a benign mesothelioma filled with fluid. Could the mesh be causing that condition? The oncologist said no. I'm actually afraid of removing mesh. Okay, so the short answer is likely not related. Depends on where this mesothelioma was in relationship to your hernia repair. So sounds like you had one failure after another, and that's why you keep getting more mesh put in. I don't like to put mesh on mesh on mesh. Sometimes it's necessary, but often just redoing, so undoing and redoing the repair is a better option than filling your belly with just more mesh, because mesh doesn't stick to mesh. There's no ability of mesh to grow into mesh or to stick to it. So those are very artificial areas where the mesh overlap, and I don't like that. Mesh does stick to tissue. That's what it's made for, to reinforce weak tissue. So when I see someone like you that has had multiple mesh placed, I kind of like to do like a forensic biopsy of your history and to see like how big was the first one, how much mesh was it put in, what was the technique, where was it sewn, etc. So I would kind of, if you don't have any problems and no hernia recurrence, leave it alone. But if you need another operation, seriously consider like just getting like a bona fide good redo of everything. And then with regard to the mesothelioma, most likely not related to the mesh. At least we haven't seen that really reported. Okay, what are the risks in skilled hands with a mesh removal with a robot for mesh in the inguinal region? Percentage-wise, what is the risk of making matters worse? My main fear is neurectomy. Okay, that's a good question. In fact, I can't give you the data yet because it's being, in about 4 days, we'll have the data. But I do a lot of mesh removal, as you all know. I do it laparoscopic, robotic, and open, depending on the needs of the patient. If you are being told that you need or would benefit from a robotic mesh removal, um, uh, my theory is that robotics, if done by a skilled surgeon, is actually better than doing it laparoscopically. We're looking at our data where we're comparing my patients who had it laparoscopic versus the ones who had robotically. Our initial studies showed that the robotic patients did better with less bleeding and less nerve injuries. The problem is that we did follow that through for more years, and they actually were about the same. So if you have a good laparoscopic surgeon or a good robotic surgeon, the outcomes are pretty much about the same. The risk, if it's an abdominal wall, neurectomy is like a non-issue. We usually don't involve any nerves in taking mesh off the abdominal wall. If it's robotically removing mesh from the groin, there's really only two nerves that are at risk, and that's the lateral femoral cutaneous nerve, which is almost never involved, and the genitofemoral nerve, which can be involved. So if that nerve is giving you pain currently, then a neurectomy may be necessary because that nerve is involved in the mesh, and I don't know why you're having the mesh removed. But if you currently don't have genitofemoral neuralgia, and your surgeon would be able to help you identify that, so that would be kind of labial or scrotal skin sensitivity, sometimes inner thigh pain, then usually we don't have to touch the nerves. In fact, most of the patients that undergo mesh removal by me, laparoscopic or robotically, do not need any neurectomy. So that's usually a good thing. I hope that helps answer your question. Okay, more live questions. Okay, so this patient says, after 80% of my mesh was removed, it was tested and results came back, quote, foreign body reaction associated with fibrosis, end quote. Should the remaining 20% be removed as well? It's only logical, right? No. We actually published on this because this is a very important point. Every single implant, whether it's suture or stapler or hip replacement or breast implant or mesh, will be sent to pathology when removed, or can be sent to pathology when removed, and every single one will say foreign body reaction associated with fibrosis. Every single one. That's just what happens to foreign bodies. It's not a negative thing. So we actually looked at all of our patients where I removed mesh, or actually removed any foreign body, suture, tacks. 100% of them pretty much had this same diagnosis, foreign body reaction associated with fibrosis. However, the reason for mesh removal was random. Some of them had a hernia recurrence, some of them had more mesh put in, some of them had an actual mesh reaction, some of them had chronic pain, some of them had neuralgia. There's a lot of people that had direct mesh problems and others who had no mesh problems, but they needed their mesh removed for another reason. All of those people had the same pathology. So the fact that your pathology shows you had a foreign body reaction, that's a pathology diagnosis. It means your body has identified the mesh as a foreign body, which it is. It's not a nefarious diagnosis. It doesn't imply that you're reacting to the mesh. It doesn't imply that any portion of the mesh, it doesn't predict that any portion of your mesh is causing any problem. We actually don't have good pathology currently to be able to identify that. I hope that's helpful. A lot of people get this pathology diagnosis and it freaks them out because they're like, oh my God, see, I was reacting to this mesh all this whole time. You may have been, but it's not because the pathology showed it. The pathology will show it whether you're reacting to the mesh or not. I don't know why you only had 80% of your mesh removed and not the other 20%, but the pathology report should not be a reason for you to go after the other 20%. I hope that's helpful. Okay, another question. Actually, hold on. This one was submitted earlier. Let's go to that question. This one has to do with incipient hernias and so on. So the question is as follows. Is there such a thing as an incipient hernia due to attenuation or weakening of the transversalis fascia or other component of the inguinal canal? Okay, so very technical question. I apologize, but that's how it was worded. So incipient hernia, I assume, means a hernia that is occult or impending. So yes, a direct hernia, there's direct, indirect, femoral. Those are 3 hernias in the groin that are most common. A direct hernia is a weakness. It's usually not a punched out hole like most hernias. It's actually a weakness, and so it's like a stretching out of the fascia. And you can be at various stages of that. You can be at the early weakness stage, or you can be late stage where it's like there's bowel in it. So it's possible that a surgeon was in the groin and said, oh, there was a impending or very early stage direct hernia and weakness. That is possible. So yes, there is such a thing. And if the incipient hernia exists, can it cause symptoms? And if symptomatic, how should it be managed? Good question. We don't know enough to say if incipient hernias are symptomatic. They can be. So there are patients where we go in surgery. If we see an impending hernia, we do address it. If the whole purpose was to address groin pain or an inguinal hernia, whereas we don't really know if there's an incipient hernia prior to surgery. Most images would not show you that. So it's more of a kind of finding intraoperatively. We think they can cause symptoms in some patients, but not in most patients. How do you define osteitis pubica and what is its cause? So osteitis means inflammation of the ostium, which is the bone. Pubica is the pubic bone. So it's inflammation or pain at the pubic bone. There are multiple different reasons for it. It could be due to trauma or any type of inflammation in the area, which can be from rheumatologic problems or instability of the pubic bone. Any kind of weird tensions on the area can cause it. Some specialists believe persistent or recurrent osteitis pubica is associated with a structural abnormality that might benefit from the intervention. Could be, depends on the patient and what their activity level is. You have to kind of correlate what they do with what their symptoms are. If you have an unstable pelvis, whether it's like due to, we have a patient today actually with unstable sacroiliac joints. And she very well may have some element of osteitis pubis because of the instability of her multiple pubic bones against each other. And she may need a stabilization, like an actual surgical stabilization of the area. And then in addition to steroid injections and platelet-rich plasma, what other treatments are there for osteitis pubica? Those are the most common. You can actually shave it down and release any tensions on it, or you can treat the primary problem, whether it's rheumatologic or pelvic instability, and actually surgically stabilize the bone. Okay, getting tons of online questions. I love this. Okay. I've been sick immediately after August 11th when my surgery was done. I currently have barred and Davol mesh, 6 by 10 inch. Can you have a foreign body reaction immediately? I've had brain fog since surgery. I'm sick all the time. The short answer is yes. We had a great hour, which I highly recommend you watch, with Dr. Trevert. He's a rheumatologist who is actually one of the more experienced people in foreign body illness, whether it's mesh illness or and mesh reactions or breast implant illness. And what you're referring to is called Asia syndrome or Schoenfeld syndrome. And it's a kind of abnormally high inflammatory or autoimmune reaction to an implant such as mesh. I think people have heard me say this before. So mesh there's tons of different types of mesh. There's thousands of different types of mesh that have been made. Usually when we talk about mesh implant illness, we talk about synthetic mesh, but you can get the same reaction to biologic mesh. And even into hybrid mesh. So not as common, but more common with synthetic mesh. The reason for that is the synthetic mesh is intended to cause inflammation, and the inflammation then dies down after a while. In some patients, that inflammation is hyperinflammation and goes on and on and on and on. And brain fog is usually a symptom of inflammation. And so surgery can give you brain fog, anesthesia can give you brain fog. Usually that all goes away. But if you have an implant that's causing inflammation, that could cause brain fog. So yes, in my experience, most patients who have a true mesh reaction, that's a systemic reaction where head to toe you're having symptoms, rashes, headaches, brain fog, chronic fatigue syndrome, blurry vision, ringing in the ear, joint pain, and swelling, burning pain, weird nerve pains. In those patients that have such a mesh reaction, it tends to occur anywhere from day 0 to like day 6 months. After about 6 months, the chances that your symptoms are due to that mesh implant are lower, not 0, but lower. So yes, it can often be immediate. You kind of have to let it ride for a while because it may be a temporary problem. So if you had surgery August 11th, it can't be from the mesh. Unless it's really severe, I wouldn't recommend having another surgery until you can make sure that it doesn't just go away on its own over the next month or two. But yes, in order to answer your question, you can get sick immediately and then have the mesh reaction kind of mess with your brain. All right, let's go back to the mesh removal question. So this is a patient that had 80% of his mesh removed, and the pathology showed fibrosis and foreign body reaction, which is expected. The question was, should he remove the other 20% because it sounds logical. So he follows up by saying, I asked because I have no more pain where the mesh was removed, but a lot of pain where the mesh and 11 tacks remain. I had a core muscle injury, no hernia. The reasoning for leaving 20% inside of me was a doctor's assistant said because the remaining mesh was, quote, intact. No further explanation was given. I don't understand it because mesh shouldn't have been used in the first place. They said for a core muscle injury, but that's a different issue. I appreciate the reply. So yeah, the mesh should be removed if that's causing your symptoms, or maybe the tacks are causing your symptoms, but it doesn't need to remove because the pathology showed that. So it's more of a diagnostic dilemma for your surgeon to figure out and see what's in your best in your needs. Okay, let's go back to the other question. This is from the patient that was sick immediately after surgery and is concerned about a mesh implant illness. The mesh I placed is Ventrolite ST. Ventrolite ST is a lightweight polypropylene-based mesh, which is currently under lawsuit. I think all mesh are under lawsuit. It's not a mesh that has been recalled. That's very different. My surgery healed up nicely. I watched the video with Dr. Baird. It was awesome. Thank you. Well, thank you for watching. Another question. Thanks for all these questions. I love it. I have had groin nerve pain ever since I had an inguinal hernia repair 4 years ago. It's painful to sit. You just mentioned neurectomy of the ilioinguinal nerve. What does that entail? I did not mention ilioinguinal nerve, but I'm happy to discuss it. So the ilioinguinal nerve is a nerve that runs from your back to the front of your groin area. If your hernia repair was done in open fashion, whether with mesh or without mesh, that nerve is at risk for injury. And if you have pain that's nerve pain, very different than mesh pain or hernia pain or muscle strain or muscle tear pain, then the nerve should be blocked with local anesthetic to see if the pain goes away. If it does, then you need more blocks or have the actual mesh, the nerve cut, and you actually like physically cut the nerve. Some people ablate it, so they either burn it or freeze it. You can burn it, freeze it, or cut it. The cutting is surgical. The burning and freezing is through the skin, so it doesn't involve an actual scar usually. So I would be very cautious about willy-nilly cutting nerves. Got to make sure that it's definitely a reason for it. Okay, another live question. I know all about the on and on of inflammation related to mesh and how it can make you feel. What, if any, are the long-term effects of this constant state of inflammation? Thank you for your question. We don't know. We basically don't feel there are any long-term effects in that once you remove that inflammatory mesh, the body should go back to normal. It may take some time to kind of wash out the toxins, so to speak. As far as we know, there are no long-term effects. Now, chronic pain is a different issue. If you have chronic pain, not just the inflammatory response, but actual pain, that the longer you deal with chronic pain, the longer it takes to heal back from it. It's possible to heal back, but it just takes longer. But as far as we know, a constant state of inflammation that you're talking about, which is like due to like a foreign body implant, once addressed, does not have long-term side effects. Okay, these are awesome. Okay, more Facebook. Like Facebook is on fire. All right, 4 mesh implants and a partial removal. Oh, is this my patient from the earlier discussion about the 4 to 5? No, different patient. Okay. Let's see. 4 mesh implants and a partial removal. Now the scar tissue is growing around my rectum and bowels. They couldn't cut the forearms out of my 4 muscle points. That sounds like a pelvic mesh issue. I don't do pelvic mesh. That's a seriously complicated situation because there are much more nerves and critical structures in the area. I would highly recommend you see people that do urogyne and do a lot of pelvic mesh removal because that's super, super tricky. So I can't answer your questions about mesh removal for stress urinary incontinence or any type of bowel or bladder issue. Sorry. All right, going back to the mesh implant illness. Thank you. Chronic pain and brain fog were my biggest symptoms. This is the patient that had the mesh implanted and in August and has brain fog. When the pain increases, the brain fog increases. I'm in the neuropsych field, so I was curious if the two were related. I appreciate the time. Stay well. Yes, there's actually, so if you're in the neuropsych field, there's a great paper that was just published, I think a year ago, which correlated brain fog as a symptom of inflammation, and that brain fog is secondary to inflammation. It's kind of a cool study if you're like nerdy like me and like to read scientific journals. Okay. All right. Let's go back to our Zoom people. How effective is neurectomy? If resected, should it be an anterior approach or retropubic, cutting the nerve proximally and injuring motor nerves? Okay, you kind of answered that question yourself. Neurectomy should be done as close to the injury as possible. The further up and towards your spine you go with the nerve and cutting that, the higher the chance you would get some adverse effects from the cutting the nerve. Most of these nerves, ilioinguinal, for example, by the time they hit the groin area, they're what we call sensory nerves. So they cause they help with sensation. So if you cut it, you will lose sensation, but they don't usually have motor function, which means it doesn't, like, your leg will still work, for example. But the higher up you go, the more motor nerves they have, so they cause function of muscles. So, for example, we used to do laparoscopic neurectomies, which I'm not a big fan of anymore. The reason for that is we cut those nerves really close to the spine, and what happens is that nerve, it addresses everything, but it's kind of a radical neurectomy. So what happens is you also lose motor function of your abdominal wall. And so one side of your abdominal wall will be weaker than the other. It's like a terrible complication. So yeah, it should be cut as close to and proximal to the injury as possible. Okay, I recently met a hernia specialist and explained low-grade deep soreness bilaterally after my inguinal hernia surgery. Apparently my surgeon used permanent tacks, which is fine. He suggests removing the tacks and keeping the mesh if it's in place. What is the likelihood that the removal of the tacks can alleviate this and get me back to normal? Have you ever just removed tacks? I have just removed tacks, but tacks do not cause a low-grade deep soreness. Tacks cause a very specific area of pain at the tack. So if you have one tack and it's right next to a nerve, for example, and that causes you pain, I could take out that one tack and leave the rest of your mesh intact. If you have 30 tacks, which I'm implying is too much, you should have 3 to 5 tacks maybe. If you have 30 tacks, so overuse or misuse of tacks in the groin, that can cause severe muscle spasm, and removing of all the tacks can help. But if you're in the middle where you just have like a normal amount of tacks and you have like a vague groin pain or something, then removing the tacks should not be the cure-all. That's, I need to know more information. I don't want you to take my word for it without more information from you. But in general, for the groin, removing the tacks for non-specific pain is not going to treat your pain, because usually the tacks are like very specific in the area of the pain. Okay, continue. If that is the case, why do many mesh removal surgeons? Oh, okay. Here's a question. Going back to the triple neurectomy. If that is the case, why do many mesh removal surgeons continue to perform laparoscopic triple neurectomy closer to the spine? If a patient had bulging from a lap triple neurectomy on one side, isn't the same procedure on the opposite side a bad idea? Yes, it's a bad idea. Don't do it. All right, I'm going to give you a little bit of surgical history. Somewhere about 10 or 15 years ago, I think in Belgium, somewhere in Europe, a surgeon talked about this kind of laparoscopic this kind of surgical neurectomy in the back. And then around 2008 or 9, I said, well, maybe instead of cutting these nerves where it's difficult, where you've already had hernia surgery, lots of scar tissue, etc., we can go away from that surgical area and go to the back. So I did like about 200 patients, 200 cadaver study where we like examined the anatomies, like 400 different nerve anatomies, about 1,200 different nerves were identified and logged in. And I took that information and presented it at a surgical conference so that people could understand the surgical anatomy back there, because it's not exactly like the books. And then with that surgical anatomy, we said, okay, look, we can now address those nerves back there. And it wasn't really clear back then, it's back in 2008 or 9. It wasn't clear back then how much motor function those nerves have. In fact, to this date, if you look at any anatomy book, it says those nerves, the ilioinguinal, iliohypogastric, genitofemoral, not genitofemoral, ilioinguinal and iliohypogastric, it still to date says those are purely sensory nerves. Well, they're not, because I started doing these and I gave a talk where I had done 3. And I was like so proud of myself, because I said, look at this great new technique. It's laparoscopic. You don't need to like go in there and deal with the hernia. And the patients did it very well. Then patient number 4, or maybe 5, got this bulging. How's that possible? So then I stopped. But I had already put out this information like this is a great idea, and other surgeons like took it upon themselves to do it. And one surgeon who's like does a lot of mesh removal published like, I don't know, like I'm gonna make up this number, but it's a lot of like maybe 100 patients, and showed how great it is and how the pain goes away. And I talked to that surgeon. I said, wait a minute, I've stopped doing this because, and I talked about it. When I give lectures, I always say, don't do this. I talked about it and I said, I've had a patient that had this bulging, and I've seen patients since then who have the bulging. Um, you did like 100 patients. Did you see that? Oh yeah, I saw it, but it's not in your paper. Like, should that be listed as a complication? Because now you're putting out this paper published in a very legit journal that says it's like a great new technique. And it kind of pissed me off because you have to present your data as objectively as possible. And if you're legitimately having 2, 3, 4, whatever number the patients is, patients with this abdominal wall that's bulging, you basically denervated the abdominal wall in exchange for the pain, which maybe for some patients that's okay because they're in so much pain, but man, you need to change your technique or reduce the risk of it or like put that out there. So that's kind of the history of how it goes. I don't do laparoscopic triple neurectomy the way I used to anymore. If a patient absolutely needs it, it's done as close to the injury as possible to reduce the risk of having motor injury. So, yes, pisses you off too. I understand. It could be a model to prove that it causes bulging. Absolutely. I wish more surgeons listened to me. I know, and I give it every time I give a talk, I talk about it. No one else is talking about it really. It's I think as lay people, you see this, you think like we must be horrible people. Uh, it's kind of hard to change, to put out information, then try to retract it. Um, and when you have papers published which show no complications, and then you see complications, people don't necessarily read everything. So, yeah, it's the worst problem is there's actually no good treatment for that. Once the abdominal wall is denervated, the only treatment is a tummy tuck, basically suturing that all, which you're a candidate for. But it's a problem. Okay, sorry, I kind of get very emotional. That laparoscopic triple neurectomy really bothers me because I've seen my own patients and other patients kind of, you just have to change what we do with that. Okay, let's see. More questions about neurectomy. What is the risk of exacerbating pain due to neuroma or phantom pain? About 5%. So we're actually in 4 days have more data on that too, because we're going to publish our experience with neurectomy. About 5% will have worse pain or recurrence of the pain, and they get a neuroma, and they need more surgery. Phantom pain, not as much, but it's more of a neuroma. So that's about a 5% risk. And of course, the treatment is another neurectomy. Okay, shoot, darn, I have such hernia mesh implant illness in the midst of a medicine epidemic, and we need to be able to be on a compassionate palliative care kind of thing until we can hopefully gain our quality of lives back for ourselves and our family. It's so true because chronic pain destroys not just the patient, but their family and loved ones and their work. That many of us are losing because we can't even take care of ourselves, and no one but another mesh wrecked patient can even begin to grasp exactly what the symptoms and pain are like when mesh goes incredibly, incredibly wrong, like it did in my case, almost immediately. By the way, I'm very sorry to hear that. Our lives as they were before polymesh, maybe polypropylene, are just gone thanks to the residual mesh coating. Not sure there's any proof of that. I can understand problems with mesh, but the residual mesh coating has not been shown, at least in our studies. This whole thing is definitely comparable to cancer, the severe symptoms and severe pain. I have 4 friends that have had cancer and ended up with pelvic or hernia mesh, and all 3 said, holy shit, please give me back the cancer straight across. Mind you, at least we'd have a support system. I understand that. Not only do well, I'm hoping that HerniaTalk is a little bit of a support system. I know it's not, but it's what I can do. I think it's all I can do. I don't know. You let me know if there's anything else I can do. Not only do we have severe symptoms on one side, then there's a severe horrific pain on the side, and I truly have 0 quality of life, all thanks to the 6-inch femoral and 7-inch inguinal hernia that was recalled. Most inguinal hernia mesh was not recalled, so I'm curious to know what you had in you, but doesn't mean you can't get injured. And to be fair, by most I mean like 98% or so of patients that have problems with their mesh, it's very treatable. You just make sure you're treated by the right surgeon. It's kind of why I do this. Okay, going back to so there's hope. Going back to the brain fog question, we have 4 more minutes, guys. You can have brain fog for 3 months? Oh yeah, absolutely, totally can. I'm currently seeking your expertise for removal. My life has been turned upside down since I'm sad to say this, but I tried to end my life because of it. Yeah, you're not the first who thought that. It's horrible, horrible, horrible. Could anesthesia cause you to feel like this? I have no pain, just the anxiety and stress. So anesthesia can mess with your brain a little bit, usually general anesthesia. We actually had Dr. Ma as our anesthesiologist to help answer those questions a couple weeks ago. And feel free to reach out to me. I know that you have, and I'll try my best to answer all your questions with an online consult or other type of telehealth consult. But anesthesia, once that is out of your system, that should be no longer a problem. Okay. Oh, I'm going to search for that paper I told you about. Yeah, it's a great paper. If I find it, I'll post it. Thank you for giving us your time. You rock. Thank you so much. I appreciate it. My whole point to my comment here is if I could get rid of the horrific symptoms, I would think the horrific pain would be a bit more tolerable, and I would like to have the ultimate neurectomy to have a better quality of life. Obviously, make sure the neurectomy is going to cure you of your pain. If a nerve block cures you, then a neurectomy would as well. Of course, I'm always available if you want to initiate a consultation with me to make sure you're in the right track. Hi, I have an upper epigastric hernia repair June 2018. I had intense pain, swelling, and burning. The mesh was removed 6 months later, and a seroma was found containing mycobacterium. Ooh. Infected seroma with mycobacterium. I then had a debridement and repair and no mesh. Then my gallbladder was removed, and I had even more symptoms of deep pain, swelling, and burning, and 2 more hernias appeared. Sounds like you're genetically prone to hernias. My last repair was for that, and the abdominal walls pulled back together. Okay. Again, there's multiple different types of mesh, so make sure you can discuss that with your surgeon about what's the best mesh for you. More of these. Okay, I try. I like to bring guests for you guys. So I'm not the one talking. You can see my throat starts getting dry. I have to keep drinking water. But I try and bring specialists so you can kind of get different views and bring my colleagues in so you can kind of know other people around the nation and the world who can help you all and give them some kind of exposure so that patients near them can, I'm happy to take care of everyone, but I can't. Many people do travel to see me, but if I can help you find someone near you or at least guide you through the case through online consultation, I'm happy to do that. 26 tacks for, oh, wow. Yeah, 26 tacks. That's a lot. If that's for a groin hernia, that's way too much. Abdominal wall hernia, it's possible you can get 26 tacks. Why aren't more suture repairs performed? We're not teaching it. and therefore generations have not taught it to each other. It's kind of outmoded. Like, why don't we wear bell bottoms anymore? It's perfectly good to wear bell bottoms, but we just don't. It kind of got outmoded by newer technology. Same reason why people don't run around with unicycles, although I'm sure there's lots of unicycles that are superior to bicycles. We just don't do it. I think we're overusing mesh in the United States. There's definitely a role for mesh. I use mesh in patients. However, it needs to be done judiciously, and some hernias do not need mesh, and some hernias absolutely need mesh. And then there's like synthetic mesh and biologic mesh. So there's a lot of options out there. And this is what I do. It's like my specialty. So I know a lot about it. Some surgeons do like 10 million different other operations too. And so, the attention given to a hernia repair, like I say, it's not just a hernia. So guys, lots of questions. Oh my God. Does mesh cause depression, anxiety? Not in and of itself, but your symptoms from it can. Any specialists in Wisconsin or Chicago area? I highly recommend you all go to the American, either herniatalk.com to search for that and for guidance in other states, or to the America's Hernia Society.com. A website, there's a find a surgeon. So anyone who's a American's Hernia Society member as a surgeon will be listed on that. So you can find surgeons near you, and hopefully that'll help. Thank you. We are over time. It's actually my birthday, so I have to go home and celebrate with my family. They're waiting for me. So do follow me on all my social media platforms, and I hope that all of you get the care that you need. If I can be of any assistance, or if you feel that Hernia Talk Live is where you can get a lot of your questions answered, I'm happy to be that person that does that for you. In the meantime, everyone, thank you and best of luck. I will post the link to my YouTube channel for this hour on Twitter, Instagram, and Facebook. And thank you for the birthday wishes, and see you all next week. Another cool guest. Take care.